Hello, everybody. It's 11 o'clock, and we're just going to give everybody a few more moments to get in the room and get their selves situated before we start. All right. Hello and welcome everybody to our first ever Alberta ALS Research Network webinar. I'm AARN Project Manager Kelsey Snow, and I'm excited and grateful to be here today, and so grateful that so many people have signed in to join us as well. Today's webinar will be recorded and posted online at a later date, and the slides will also be available. If you'd like a copy of the slides, you can post a message in the chat or send me an email and let me know, and I can get those to you. AARN is committed to advancing research and improving care for amyotrophic lateral sclerosis through strategic investment in fundamental, translational, and clinical research. AARN aims to position Alberta-based ALS researchers as global leaders by fostering innovation and collaboration to accelerate discoveries and enhance patient outcomes. The research network is powered by the ALS Society of Alberta through the generous donations of people in our province. Today, we are bringing you an update on the Jennifer Prest Bulbar ALS Research Fund. This work began before AARN got off the ground, and we are so excited to know that it will keep going thanks to continuing support from Jennifer's husband. Our speakers today will be Dr. Gord Jewett from the University of Calgary and Dr. Yana Yunusova and some of her student researchers from the University of Toronto. Dr. Gord Jewett is an ALS neurologist at the University of Calgary with research focused on ALS. He is the chair of the newly formed Alberta ALS Research Network, which will make strategic investment in ALS research to create a better future for people affected by this disease. Dr. Jewett's research focus is on population-level ALS registries and digital tools for early diagnosis, assessment, and management of ALS. He is particularly interested in finding better ways to diagnose bulbar ALS and treat bulbar ALS symptoms. Dr. Yana Yunusova received her PhD in speech language pathology from the University of Wisconsin-Madison in 2005 and joined the University of Toronto in 2007. She is currently a professor in the Department of Speech Language Pathology. Dr. Yunusova is also a senior scientist at both the Sunnybrook Research Institute and the Toronto Rehabilitation Institute, part of the University Health Network. Her research is focused on elucidating the neural mechanisms that govern speech production and on investigating the speech and orofacial impairments in neurological conditions such as ALS, Parkinson's, and stroke. Continuously funded by the National Institutes of Health since 2009, her research program is dedicated to developing advanced technologies for the automatic assessment of orofacial dysfunction and speech disorders, as well as innovative speech therapy approaches aimed at transforming clinical practice in speech language pathology and neurology. And with that, I am going to pass over the screen to Dr. Jewett, and he is going to start us off.
Thank you very much, Kelsey, and thank you for the intro. Everyone can see my slides there? Yeah, I see a few nods. Perfect. So most people here, I suspect, know a fair bit about ALS, but I won't assume anything. So, as many of you probably do know, ALS is characterized by weakness and progressive weakness that can start in a lot of different muscles in the body. And that weakness is caused by degeneration of the cells or neurons that connect our brain down through our spinal cords and out to muscle. ALS is challenging to diagnose because it can start in a lot of different segments. So you can have bulbar onset ALS, which means ALS that starts with bulbar symptoms, including swallowing difficulty and difficulties with speech. And some people can have onset with difficulty breathing in respiratory onset ALS, or a disease that starts with limb weakness in the arms or legs. About 30% of people with ALS will initially present with those bulbar symptoms, and that's what we're really going to focus on more today is this problem and solutions to this problem. But about 80% of people with ALS will develop bulbar symptoms sometime in the course of their disease. So most people with ALS will eventually have speech or swallowing difficulty that we need to find solutions and improvements in their treatment and management. Bulbar onset ALS and bulbar symptoms of ALS are particularly challenging for several reasons. The first is that bulbar onset ALS is difficult to diagnose. And so you can imagine, and many of you here may have some experience with people that develop some mild difficulty with speech, maybe a little bit of slurring of speech, and that's gradually getting worse. And it's very difficult for most physicians or for people in the public to know what those causes may be. And ALS is a cause that often has a delayed diagnosis. So we know now, based on the generous donations from Jennifer Prest, that in Canada, the average time to diagnosing bulbar onset ALS is about 1 year. And so that's 1 year of frustrating appointments going to doctor or nurse to nurse before getting a diagnosis. And that's really significant when you think about the fact that on average, people with ALS that starts with bulbar symptoms survive about 2.5 years or just over 2.5 years. So that means that those people are spending nearly 40% of their remaining life trying to get a diagnosis and an answer. The other challenge is that bulbar symptoms are often life-limiting symptoms, particularly swallowing difficulty and difficulty even swallowing saliva. And so maintaining weight and nutrition is challenging, and avoiding fluids going down the wrong way into the lungs and causing aspiration is a really challenging problem. And of course, some people will lose the ability to speak entirely or will not be able to speak clearly. And that's a really socially isolating and frustrating symptom. Jennifer Prest and I've got a typo here. That's terrible. I apologize. It says Jennifer Present. So that was a rushed job of slides. I apologize. But Jennifer was really an amazing woman. She had bulbar onset ALS, and she had a very frustrating time to get a diagnosis. So she went to many, many doctors in Canada, had delayed evaluation by neurology, and got so frustrated in that process of camping out on doctors' steps and really advocating for herself that eventually she went to the US and had a diagnosis made there before I ever met her in our ALS clinic. Jennifer was a really powerful advocate for people with bulbar onset ALS or bulbar symptoms of ALS. And before she died, she created the Jennifer Prest Bulbar ALS Fund through the ALS Society of Alberta. And she made a very generous $100,000 donation. And we're going to talk about the research and work that her donation funded and is funding to date. And then, as you heard from Kelsey, her husband has made a very generous donation again this year. And we're inviting you all to match that, and everyone in our community. And so this QR code will take you right to that donation page if you'd like to make a donation. And hopefully by the end of today, we'll convince you that these are important donations that we can make good use of to further the world of bulbar ALS. So I'll stop sharing my screen there. If you missed the QR code, you can access that through the ALS Society of Alberta website as well if you'd like to make a donation. And I'll pass it over to Dr. Yunusova at the University of Toronto now, who's one of my close research collaborators, and she'll share some of the great work along with her students.
I'm almost there. Give me one tiny. For some reason, I don't see my slides and the share.
We all know the struggles of trying to share screens. When there's an audience there, it's always harder.
While Dr. Yunusova is doing that, I just want to pop on and say, if you have questions, we will have some time after for questions. So you can put them either in the Q&A or in the chat, and we'll make sure that we ask those questions before we wrap up.
I'm still slightly struggling. I'm just wondering if, Kelsey, I did send you the slides. For some reason, they're not popping in my shared space.
Okay.
Oddly. Oh, no, they're now in.
Oh,
wonderful.
There we go. Okay. Crisis averted.
That's right. The moment that I panicked, the problem got solved all by itself without much of my doing. So here we go. And thank you, Kelsey, for the introductions. And Dr. Jewett, Gord, thank you for inviting me to do this important research with you. And I think one of the key reasons for donations into this fund is that it really supports multidisciplinary collaboration that is so important for solving this significant problem for both bulbar diagnosis, but also detection of bulbar signs with disease progression. Researchers and clinicians know when patients develop bulbar signs, which sometimes is difficulty speaking clearly or as clearly as people used to speak, slowing down speech, or challenges with swallowing, the disease takes a different course. And we really are working very hard to make sure that we're able to detect these changes in how ALS develops as early as possible in order to be able to predict what's going to happen down the road, in order to provide the available services as early as possible, and generally support people through their ALS journey, because we do understand and realize how complex that journey is. So mostly what right now I'm a director of what we call bulbar function laboratory at Sunnybrook Research Institute and Sunnybrook Health Science Center at the Toronto and the University of Toronto. And the majority of my research program currently is focused on one hand, developing assessments. In my lab, we have developed some standardized clinical assessments, clinician-administered tests, but of course, they take a lot of time. And when patients come to the clinic, and many of you may have experienced this, the time in the clinic is very precious. Each patient sees multiple specialists. There is kind of this sense of rotation from one specialist to another. And in some clinics, the time with each specialist, particularly in very, very big and busy clinics, it may be limited. So what we're trying to do is we try to make the diagnosis of bulbar ALS faster, more precise, more specific, more sensitive, and finding some technological means to do it and deliver the assessment results to clinicians in time for them to see patients. And that's how you're going to meet a couple of students, engineering students in my lab, who will tell you a little bit about their research in this domain. So the focus is on automatic remote assessments to basically decrease the burden on patients and clinicians and improve patient access, particularly as in the case of Jennifer Prest, access to the sensitive diagnosis, even potentially outside of multidisciplinary clinics where diagnosis is usually relatively rapid. It's the path to that right center, to that right place, is what makes the diagnosis challenging. We also are working on developing better, more relevant, and more patient-focused management practices. And in this, the work in my lab is, as I already told you, working with neurologists, working with engineering, but also working with clinicians such as speech-language pathologists to create tools and practices that make sense to them so that they implement these practices with ease and don't feel like, oh, I need to learn yet another complicated tool or another complicated process. So that the diagnosis and the assessment process becomes more organic, more easy to execute, and in addition to it being accurate and specific. We also, in my lab, or a couple of years ago, we started a community of practice for speech-language pathologists working with patients with ALS. We call it SLPs for ALS, which provides the opportunities for continuing education. So in my lab, the work really is across the entire path from detecting the disease, supporting neurologists in providing timely and accurate diagnosis, monitoring for bulbar disease progression with sophisticated tools as we're developing them, working with clinicians to make sure that these tools are organically implementable in their practice, and training them through continuing education opportunities so that everything gets delivered to patients in sort of a very cohesive pattern. In my lab, the primary sources of data that we collect are what we call speech acoustics, or just basic recordings of speech, and recordings of speech movement, or we call it speech kinematics. Kinematics basically stand for movement. And we ask patients, we now have a remote software, we call it virtual SLP, and we ask patients to help us collect speech and non-speech data. We ask patients to speak sentences, syllables, read a passage, and also perform some, we call them non-speech tasks, which usually are standard tasks that neurologists and speech pathologists use in their neurological examinations. And then we also conduct many patient and caregiver and clinician interviews. And you will see examples of that kind of research as my students talk about their own research. One example that was a very concrete delivery on the funds that Jennifer Prest Fund provided was our collaborative project on using speech acoustics in differentiating upper versus lower motor neuron diseases using automatic acoustic analysis. This paper has already been published in the Central Primary ALS FTD, we call it, journal in 2025. And Dr. Jewett and I were collaborators on this project together with our students and some other neurology colleagues. For this study, we recruited patients with primary lateral sclerosis and Kennedy's disease to identify patterns associated with either upper or lower motor neuron presentation. And this work is actually used also to develop a model, an automatic AI-based model, to identify features of the mixed or ALS presentation, and within that mixed presentation to be able to say if the patient has a predisposition or predominantly upper versus lower motor neuron ALS. So that's one of the examples of our deliverables. And this is an example of what kind of data we obtained. In the video on top, you see a patient saying sentences, bye, Bobby, a puppy. And at the bottom, an individual making non-speech tasks. And now we have this AI, very sophisticated models that without putting sensors on people's faces and tongues, we are able to make measurements that tell us something about the disease onset. Is there features of the disease, and also how the disease progresses over time in these patients. So which helps us to design automatic, what we call neurological or cranial nerve assessments, automatic speech assessments, and even now we're moving into the automatic assessment of tongue, which you will hear shortly about. Okay. And with that, I want to introduce Mari Kadyrova, who is a second-year PhD student, co-supervised with my colleague from Electrical and Computer Engineering Department, Dr. Irvin Sejdik. Mari will tell you a little bit about her project, her engineering project focused on tongue movements. Mari, to you. Just tell me when to switch slides.
Sounds great. Thank you so much, Yana, for introducing. And hello, everyone. I hope you all are doing well, and thank you for joining to this talk. As Yana mentioned, my name is Mari, and I'm a PhD student at the Department of Electrical and Computer Engineering at the University of Toronto. And I'll go over a little bit of my research. My research focuses on developing ways to remotely assess the severity of bulbar function in people with ALS. I focus specifically on the tongue, which is often the first and most important articulator affected in the bulbar ALS. And today I'll share some of my work and where we hope to take it in the future. So with the rise of high quality cameras and advances in telehealth, remote assessment has become more feasible than ever. Using commonly available cameras, we collect videos of patients performing simple tongue tasks. These tasks are adapted from the cranial nerve exam, which is the standard clinical assessment used for motor neuron diseases. And I'm going to ask Yana to play on the left the video, which is an example of these tongue tasks from a participant. You can see just a simple lateral movement of the tongue. And by analyzing videos like this, we can assess the tongue movement and ultimately bulbar function. To do this, we first need to detect the tongue in the video. We use computer vision and machine learning techniques to identify and segment the tongue, allowing us to evaluate its health and movement. And I'm gonna ask later Yana to play this video. It's an output from our computer vision model where the tongue is highlighted in green. However, I want to give a warning, there is flashing images, so please take care if you're sensitive to the flashes. And if you'd like to play Yana one more time, just to show the output of the model. That basically localizes the tongue in the videos. And going on to the next slide. For our future work, we want to focus on reliably and accurately quantifying tongue health and movement to assess bulbar function severity in people with ALS. So we plan to analyze remote videos collected from our participants to track tongue motion using the outputs from our machine learning models. To ensure our results are accurate, we will compare them to the gold standard technique of electromagnetic articulography. And the image on the top with one of our master's student, Judy, is showing how this experiment is performed using the sensors and detecting how the tongue moves using the sensor on the tongue. This will allow us to validate that our remote video-based assessment is as reliable as current clinical methods and the gold standard of electromagnetic articulography. Next, we will perform clinical validation by examining how features of tongue motion, which Yana already mentioned, kinematic features, how these features will relate to established measures of bulbar function, such as the ALS Bulbar Dysfunction Index, which was developed in Dr. Yunusova's lab. And to conclude, our work aims to create a safe, remote, and reliable way to monitor ALS progression, giving patients and clinicians more accessible tools to track changes in bulbar function over time. We aim to improve care, support timely interventions, and ultimately enhance quality of life for people living with ALS. And let me know if you have any questions later on. Thank you, Anna.
Thank you. Kelsey, I'm just wondering if we should leave question period at the end, or should we introduce questions as we're talking about or presenting different projects? What do you think we should do?
I will leave it up to you. I haven't had any questions come through so far, so maybe at this point, if we wait a little bit longer.
Okay, sounds great.
Okay.
We'll then leave the questions to the end. Mary, thank you. That's wonderful. As you can imagine, this is a very complex type of work, but the way it will advance eventually, the diagnosis of bulbar ALS, it seems like a little bit of a dream right now, but imagine having an automatic tool that may be part of, let's say, healthcare management software that would allow a small recording of a patient video or a video of the tongue to be analyzed through the machine and identify changes in the tongue that's characteristic of bulbar presentation that would reduce some of the burdens associated with maybe second guessing the diagnosis, or generally maybe adding additional information to what neurologists and speech language pathologists have already in front of them, basically serving as a supportive tool. So thank you, Mari. And I'm just moving on to my next slide. And with this, I'd like to introduce Vishnu Akundi, who is also a second-year PhD student in my lab, co-supervised with my colleague from Electrical and Computer Engineering at U of T. And Vishnu will tell us a little bit about his project.
Hi, everyone. Lovely presentation so far. Hope everybody's doing well. So as Yana said, my name is Vishnu. I'm a PhD student at the University of Toronto's EC department. And my work is focusing on developing new ways to detect and track bulbar ALS using multimodal approaches. So one of the biggest challenges with bulbar ALS is that the earliest signs are often incredibly subtle, right? You can have slight changes in speaking rate, the smallest reduction in your jaw or lip mobility, or even just a pause while you're reading a passage that's just a fraction longer than usual. So these are very small changes that are very often very difficult to detect for a clinician, even a trained clinician. So especially because in ALS, presentations can be very heterogeneous. Clinicians can miss these very small fluctuations. So what we're working on is a way to make these changes, early changes, much more visible, measurable, and detectable. Using something that feels very simple to the patient. So as Yana said, as has been mentioning, just these simple recordings, right, that they can do from home using their laptop. And so on the left here, you can see an example of a patient performing a task, and we extract kind of two streams of information from this. We extract the kinematic information similar to what you saw from Mari's slides. We have these facial landmarking systems that will extract all these little features about their jaw movement and their mobility as a whole on the different muscles in their face. And then we also have the acoustic feature extraction side, where we extract things like their pitch throughout the task, or the formants as they're speaking, as they're going through different passages. So we take all of these different features that we've computed from these two different modalities, and we give them to an AI. And the AI basically is trying to find these small fluctuations, these small patterns that maybe for a human is very tough to find, but when you give all of this data to an AI model, it can figure out those patterns much more easily and tie them to a patient's severity, a bulbar severity. So our goal here is to help clinicians identify bulbar involvement months earlier, so that families don't have to experience these long periods of uncertainty, and care teams can take action much sooner. So we can go to the next slide. So I wanted to just briefly provide some results, I guess, that I've gotten using this line of questioning. So I would point you to the first plot here. What you see here is a figure showing what happens when we remove different tasks from our assessment protocol. So for example, we have these non-speech tasks, like Yana said. We can think about not including those in the protocol and seeing how that impacts model performance. The reason we want to do this is because if you're already suffering from ALS, doing a very long protocol is very cumbersome, right? And it's in our best interest, it's in the patient's best interest to kind of limit the length of the protocol while still preserving our predictive capabilities. So we want to find that optimal set of tasks in our protocol so that we don't lose any predictive power, but we also make it easiest for the patient, right? So what we find is that actually there's just a handful of tasks that provide most of the predictive power in our protocol, and some other tasks can be entirely dropped from the protocol. So what this, again, tells us is this multimodal approach gives us a way to streamline our current setup. So I found that to be a very interesting result. The second plot here shows kind of the general performance metrics that we're seeing for our prediction models, because obviously this is a very tough problem for any AI, even when you have a lot of data. But what we see here, and this is very important, is that regardless of our severity levels, we're seeing very similar and very high performance metrics across the board. So that tells us that even when the predictive task is very tough, so when things are very nuanced and it's very small fluctuations, our AI model is still able to capture these at similar rates to when, the presentation is much more obvious. So this again tells us that this AI approach is kind of a very valid way to approach this problem. So overall, these results tell us that multimodal analysis can make these assessments much more accurate, more efficient, and more patient-friendly without losing the nuance needed for clinical care. Thank you.
Thank you, both of you. So basically, to sum it up, in addition to developing clinician-administered tools that can be used by humans in the clinic in a clinical context, we believe it's really important to develop some automatic supports, not to substitute the work of a clinician, but support the accuracy of diagnosis, the timeliness of the diagnosis through identifications of signs that are so subtle that may make a clinician wonder, am I seeing it? Is this right? Maybe I'm just oversensitive to the problem. So to help, that's where I think the true role of AI and the AI modeling would be. So thank you, both of you, for your excellent work and being wonderful students and making this work happen. The third student I want to introduce today is Anna Huynh, who is a six-year PhD student in Rehabilitation Sciences Institute in Speech-Language Pathology. She's conducting qualitative research on the advancing care provisions for patients with bulbar ALS. Anna, I don't see your camera is on. Can you please, are you there?
Hi.
Hi,
Hello.
Anna.
Hi, just joined.
Hello.
Sorry about that.
Okay, no problem, no problem. I'm glad that you're here. It would be wonderful if you tell us about the research that you've been doing and the impact this research would have on patient care.
Of course. Hello, everyone. I'm sorry I'm a bit late. I was just presenting to ALS Canada literally like less than 2 minutes ago. So I'm jumping in here now. Nice to meet you. I'm Anna. I want to share that I'm someone who stutters, so sometimes it might take me longer to speak. If you don't understand anything, happy to clarify. So my dissertation research focused a lot on kind of thinking about patients and helping them throughout the disease from a speech and swallowing perspective. So as you may already know, nearly 80% of people living with ALS will eventually develop problems with speaking and swallowing, which is one of the most devastating things that can happen to people, according to a lot of research and me speaking to patients. And that can affect their quality of life and also their prognosis. And from a clinical perspective, as a speech language pathologist, we often want to start interventions as early as possible because we know that starting these interventions early will really help make the most out of the interventions and improve outcomes so that people have enough time to really think about the interventions, trial and error, and make it more unique to them and what helps them the most. And so there are a lot of different decisions that people have to make when it comes to speaking and swallowing, from not only considering about banking their voices to using communication devices when they are no longer able to speak or be as well understood, to changing their diets from, eating their favorite steak to now maybe they having to make it a little bit more softer. And as times goes on, maybe they aren't able to be eating or speaking in the same way that they used to. So patients and their families really have a lot of complicated decisions that they have to make. And there's often not enough guidance and support to provide these people. And so my research really helps to focus on providing patients and their families with the support to make these decisions. And that will then hopefully help them to navigate the healthcare system, which often there's so many different components when we're thinking about there's like neurologists involved, respirologists, occupational therapy, physiotherapy, social work, speech and pathologists, each of which have their own set of interventions. And so thinking about interventions themselves, there's, you have to think about what it is, how does it work, what are the pros, the cons, et cetera, et cetera. And so having that kind of support was one of the things that patients had and their families have spoken about. And my research really aims at focusing on that part. So my work tries to develop a shared decision-making tool by following a framework, which basically focuses first on kind of identifying what works by looking at the evidence and identifying from research what interventions are effective and actually based on good quality evidence, so that these are interventions that can be shared with and recommended to patients and their families for managing their speaking and swallowing, as well as kind of clearing their airway when thinking about coughing. And this work basically identified that there are lots of interventions that currently exist, and that this work is has identified the need for maybe different tools for different types of interventions. And then from there, thinking about, okay, we looked at the evidence, now let's talk to the people who are involved. So thinking about people living with ALS, I spoke to patients who had speech and swallowing symptoms and those who didn't, just to understand what their decision-making experience is and what their needs are, so that we can create a tool that is actually meaningful and addresses their needs. And then I also spoke to clinicians about their experiences and their needs to understand what exactly is happening when they are supporting patients and their families, just to see what can help, and all of which kind of led to the fact that people are looking for more decision-making support that is, on one hand, focused on giving patients kind of information that is personalized and contextualized and relevant to them, but not so much so that patients can really customize information so that it is appropriate for them and their situation. And for clinicians, really thinking about, okay, not just the information aspect, but supporting decision-making in different ways, thinking about supporting people to think about what matters most to them, and kind of figuring out how to bring those types of conversations in a way that is not too much and is kind of manageable. Overall, my dissertation kind of puts together all of these to hopefully create a tool, which is going to be my future work and Yana's future work, to think about tools that really support timely and personalized care in a way that makes sense to and matters most to patients and their families.
Thank you, Anna. And with that, I'm going to stop sharing my slides. I hope I did stop sharing my slides. And maybe open this up for discussion, or maybe see if Dr. Jewett wants to wrap up this project-specific part of the presentation. But anyhow, it's to everybody else.
Yeah, thank you very much. That was really interesting. I hear a lot about all of your projects, and but really interesting to hear you speak all about them, and nice to share the work that's going on. It's very exciting. Maybe we'll switch over now, and I'll let Kelsey run the question and answer now. I think there's a few questions that have trickled in, and if people have questions that come up as we talk, feel free to post them in the question and answer or in the chat.
Yeah, Mari, we had a question for you. Sometimes people with bulbar issues have involuntary twitches in their tongue. Can your system detect these twitches, and does the presence of twitches alter the tongue movements outcomes you're showed?
Thank you so much for this question. This is a very interesting question. And we definitely have seen participants having involuntary twitches. We call them fasciculations. And that can be one sign of bulbar ALS, especially when it comes to tongue deterioration. When it comes to the remote assessment and remote collection of the video, it's extremely hard to see these twitches on the 2D videos. it's easier with the 3D, which what I kind of touched on with electromagnetic actigraphy, where you can kind of maybe detect those fasciculations easily compared to 2D videos. So that is something that is definitely we want to experiment with and see if we can detect them, because we do have videos collected at high frame rate, ideally being able to show these involuntary twitches. However, there has not been any research on 2D videos being able to detect fasciculations, and hopefully I'll get to that point, to that study in my research. However, right now, to answer your question, the system cannot detect these twitches because there needs to be a really, I guess, detailed procedure in detecting them. But right now, we don't have that procedure.
If I may add just a little bit to that answer, Mary, that was really excellent. In order to train a model for automatic detection of fasciculations, we need to have a lot of data. And let's say we have a data set of about 100 patients, only maybe 20% in that data set have fasciculations. It doesn't mean that they don't have at all these fasciculations in, let's say, clinical assessment, but when the video was recorded, only in about 20% we were able to document on the video fasciculation. So it's not enough data. So of course, in addition to donations and funding for work like ours, we also always seek more participants, allowing us to video record them and then analyze their tongues, their faces, and their speech to get these models working.
And to add
Yana,
on, Yana, you
sorry,
inspired me to add on to that, because I was watching every single video of the participants we have with all the tongue tasks they recorded. One very important thing is the data quality. That's another thing with the 2D videos. It's very important to have the light in the right direction, to have the right equipment, which we are not even trying to have that. We have super uncontrolled environments, patients in their houses recording videos in their most comfortable positions at their tables with their laptops that they've been using for years. And being able to control for video quality is very hard. So we will try to see if it's even possible in the future.
Yana, I would just like to ask, how is your work open right now, accepting more participants? I know you just mentioned that you need more participants, and how could people join if they wanted to participate?
Oh, that's a fantastic question. The best would probably to email me directly, and I don't know if we have an enabled chat or
Yeah, we do.
yeah.
The
So
chat is enabled.
I'll put my email into the chat, and people can send an email to me, and I will refer them to my lab manager, Madura, who recruits patients and records these assessments remotely, or help them to set up and make sure that the data is as best quality as possible. And so, yes, we are open to engage more patients.
Amazing.
And I'll just add to that, we will also very shortly be recruiting for some of these studies in the ALS clinic in Calgary too. So for anyone who's a patient or a family or friend of patients followed here, we will make that opportunity available here too, as soon as we get some legal barriers solved.
Mhm. Okay, another question. I'm wondering if you can say something about laughing and how bulbar ALS affects laughing.
Yeah, I'm happy to touch on that. So bulbar ALS, or anyone with ALS that gets bulbar degeneration, can get symptoms that we refer to as pseudobulbar affect. And these can involve sometimes inappropriate laughter. And you can think of it as, we all have an urge to laugh and we all laugh at times, but the brakes are taken off that urge at times. And that laughter can sometimes be quite loud and not easily controlled. And often that laughter will come out even when that level of humor is not felt. Along with that can come a symptom of tearfulness that is also a pseudobulbar affect symptom, where people will get tearful. And, I get tearful when I watch a Disney movie, but some people don't do that, but they will develop it during the course of their disease. And sometimes that can be really, really problematic because people don't want to express that level of emotion and can't control it. There are some medications we can use to improve that, but it is an area of symptomatic research in bulbar ALS that there's still a lot of work that needs to happen. And that is also a symptom that's not very well recognized by some primary care providers. And so sometimes it can be missed as an early sign of ALS.
Or Dr. Jewett, sorry. Is there an understanding in a disease where we are talking about nerves, why laughing and crying would be impacted? We wouldn't necessarily draw as a patient, a former primary caregiver of a patient. That's not a normal, I don't think, parallel that most people would draw to each other.
Yeah, and so we think of ALS as being a disease of degeneration of motor neurons, so our nerve cells that connect to our muscles. There is degeneration of other neurons as well that are not just motor neurons. And so exactly where those neurons are in the brain and the lower brain that cause this symptom, the pseudobulbar affect, which includes the laughing, is not very well understood, but it is probably a reflex that no longer is inhibited. So we all have these emotional reflexes, and our brains naturally inhibit them. And that ability to inhibit is lost because some networks within the brain start to break down.
Thank you. I have another question. Some clients have an increase in nasality, which clients find hard to deal with as their voice has changed. Has or is this being looked at?
And that probably a good question for me to take. Yes, and importantly, for the listeners, having what we call hypernasality is one of the hardest pieces that affects how intelligible or how easy to understand speech is. So it's kind of a double whammy. It's really hard for patients to experience because through the nose now they're losing a lot of air that interferes with respiration, that can be impacted, or in many patients is impacted. So there's this component plus the component that listeners are now struggling with hearing that hypernasal kind of speech and trying to understand it. So yes, and so what we are trying to detect is also changes in hypernasality as early as possible as part of that diagnostic journey, as contributing, because it's also this kind of speech is associated with the presence of lower motor neuron impairment, which to achieve our overall aim to improve diagnosis of bulbar ALS would be very, very important. We're trying to detect it, but it's also very hard to do on the acoustics. So we are still developing the actual specific measures that detect that kind of change. But it is exactly very important, and our models will be able to do it as time goes by.
Is there any, I would ask, is there any advice for management of that? My husband struggled with this. So anecdotally, we found that when he was tipping his head back and his palate sort of wasn't, dropped, that made his voice less nasally. And I know we were also directed to sort of a palate device that works for some people. So I wonder if you could speak to any of those sorts of tricks.
Absolutely. And positioning is one of them because gravity can be a great help. And so sometimes in the semi-decline position, in a let's say kind of a recliner type of chair, it could be less. Another kind of device to overcome it. Some people use it particularly on the phone in the phone conversations as a nose clip, because basically clipping the nose completely turns off that nasal channel. And so the speech doesn't sound as natural as it would be without the nose clip, but it sounds more intelligible. So that's another trick. And of course, for some patients, not for very many, but the what we call a palatal lift can be an option. But a patient has to qualify for that device in a very specific fashion because, of course, if somebody struggles for air, it would be hard to have a device that increases what we call resistance in the oral cavity, and then the breathing would affect breathing and make it more challenging. So in many cases, the easiest solution is basically clipping your nose for those moments where communication needs to be more precise, and also adjusting your body position, your head position.
Well, the good news is anybody in the ALS world has a plethora of nose clips available after all of their clinic visits, right, for their breathing tests. I have another question. Do you have any insights about levels of lead in ALS patients? Is this an area of study for researchers here today?
Yeah, I can jump in on that. We know that lead poisoning or lead toxicity can cause a motor neuropathy. And so that means that the nerves degenerate and it can cause weakness, and it can often mimic some of the early symptoms of ALS. So in specific people, we do screen for lead, although to be honest, it's very uncommon in Canada now. So we used to screen everyone we diagnosed with ALS in Calgary for lead toxicity. And in 7 years, we never found a single person with an elevated lead level. The neuropathy with lead toxicity does tend to present a little bit differently, and they tend to have other findings on their lab tests that give us a clue, like changes in their blood cell counts. And so we don't typically screen for it, but there is a lot of work going on both in Canada and internationally looking at environmental factors that may influence ALS. And there's some large registries that really help with this, such as the Canadian Neuromuscular Disease Registry. But it is not something we screen routinely in everyone, just unless there's clear clues that that could be a cause.
Thank you. Anna, a question for you. What are the reasons that people struggle with using assistive speech devices? Some people are early adopters, whereas others are more resistant. One friend felt like the speech system created a disconnect with their 5 and 6-year-old daughter. So they did not want to use one.
Thank you so much for the question. I think that's a great question, and an area where hopefully kind of having more conversations about this might be very helpful. And I think, Calvin, you were very attuned as to why. So when you think about these speech devices, these technologies, people have varying familiarities with a variety of speech devices, and so these are not only difficult to use, but it takes time for you to become more familiar with it, to become more faster with it. And also when you think about communicating using a device of sorts versus just speaking naturally, there is a layer of, it takes longer, I guess, to simply, and regardless of how efficient you are with texting, for example, it will not be the same as if you were to speak. And you also lose a lot of different layers when you think about communication, not just the words, but like the intonation and the kind of emotion, which will come from other aspects of your voice that is not necessarily present with a communication device. Same with like facial expressions, all the nonverbal aspects. So on one end, the technology is good in terms of being able to communicate something, but it does lose a little bit of other aspects of communication. So that is one reason. And the other reason, when you think of earlier I mentioned how people believe that they can connect with one another and kind of engaging someone's identity and how what kind of meaning they attach to communication and connection can differ. So if someone feels that they don't feel like they can connect with their loved ones, then that would be a reason why they feel like, okay, I don't want to use this. But it might mean that for a clinician is kind of explaining to them that this is one aspect of communicating the message, but you can connect with another person using other ways as well. So you can still use your, your voice or your facial expressions, to be connecting with someone or doing other activities with them. I remember there was a patient that I knew that used to paint. So maybe it might mean that you can connect with your daughter by painting and doing some shared activities together, and just being in that same space is a way to facilitate that. Hope that answers the question.
Thank you, Anna. I don't have any more questions. Nothing else has come in. So I really want to thank all of the doctors and the students for today. It was really informative. It was so well done. We're so grateful for your work. Speaking as a former primary caregiver and someone who's lost someone to ALS, it means the world to our community for you guys to be here and to be doing this. It really does make a difference for us. So thank you for sharing your work with us today. Thank you to our guests for joining. As we approach Giving Tuesday next week, you can follow the QR code on the screen there if you would like to show your support, or you could also go to www.alsab.ca/donate if you would like to donate there. We're so grateful to everybody for joining our first webinar. A few small technical glitches, but overall I think it went better than we all anticipated or hoped. And the ALS Society of Alberta and the Alberta ALS Research Network would like to wish you all a safe and restful holiday season. Thank you so much for joining.
Thank you for the invitation. All
Have
the
a great
best.
Thank you so much.
Thank you.